everyone. Welcome to Blood Matters podcast for nurses. As you can see, we've got a new look, new season, and we're bringing in a new co-host. So there are going to be three of us running the podcast going forward. And I'd like to introduce Hilda Mecklenkamp, who is actually the new president-elect of the EBMT Nurses Group. Hilda, would you like to say a few words about yourself?
Yeah, of course. Good morning, Michelle. Nice to be here as a co-host for this very wonderful podcast. My name is Hilda Mecklenkamp. I work in the Netherlands as a pediatric stem cell transplant nurse and as a postdoc researcher, and I'm very glad to be the president-elect of the Nurses Group and looking forward to also this new season of the podcast.
Thanks very much for joining me, Hilda. And without further ado, let's move on and bring our guests in.
Today we have Jenni and Lorna with us, and we will start with Jenni. Jenni, can you introduce yourself and tell a little bit about what you do?
Yeah, hi. So I'm Jenni Davies. I'm a haematology research nurse in the University Hospital of Wales in Cardiff. I've been in post for nearly 6 years now. I originally started on the stem cell transplant portfolio, and recent years I've been working on the lymphoma portfolio. And I have recently become a nurse PI in a chronic lymphocytic leukemia trial, which I'm really excited about.
Great. Lymphoma and its treatment have become very exciting in the past few years, and we're keen to hear about that from you. Now, there's quite a few diagnoses that fall under the umbrella of lymphoid malignancies, and today we're going to focus on lymphoma itself, and we will cover Hodgkin lymphoma in another podcast, and the current landscape and what that means for nurses. Can you summarize us the changes we have seen in lymphoma treatment in the last 5 years?
Yeah, sure. So, like I said, I've been post for nearly 6 years. So to see a lot of these changes has been really exciting for me. My keen interest is in research, so seeing these projects coming through. For instance, CAR T therapy in Wales, it's now become second line of treatment in lymphoma, third line or for relapse. And it's just great to give the patient that extra option when they're going through treatments. It's also helped our nurses. There's lots more specialists positions become available. And it's a great way of linking the nurse specialist as an advocate for the patients with the consultant, because it's a long journey for the patients, and they just need that extra hand, just to guide them through. And the education and development for the nurses has been brilliant.
Thank you.
Thanks, Jenni. I mean, so we're at episode 12 of the pod. We're talking about lymphoma today, and there are loads of new drugs that work in quite smart ways for lymphoma, thinking in particular about some of the targeted drugs, ibrutinib and the such, and antibody therapies, and anti-drug conjugates. Can you talk us through these a little bit and how they work and how they're used in combination with other treatments?
Yeah, so a couple of drugs that like ibrutinib, for instance, bruton kinase inhibitor, or BTKI, as we know in the industry. This is used for a lot of lymphoma cancers like mantle cell lymphoma, Waldenstrom's, and CLL. It can also be used to treat chronic GVHD with post stem cell transplant, and it's the kinases are proteins that help the cell grow and divide, and the ibrutinib then blocks that protein to stop the cells continuously dividing. I know ibrutinib works very well with rituximab, which was used a lot previously on its own. And rituximab is a monoclonal antibody that targets the CD20 protein of the B lymphocytes. And they work really well together to keep the patients in, keep the disease away for longer so that the patients have a better outcome. There's a lot of studies that have gone through that have proved for I know CLL and Waldenstrom's that they work really well together, and the percentage of overall disease survival is a lot higher when used in combination rather than together. And there's another drug that under the ADCs, the polatuzumab, sorry, I can't say that. The polatuzumab, it's an antibody that targets the CD79, which is expressed on the surface of the malignant B cells. And there's quite a few combinations that this can be used with, generally to treat diffuse large B cell. Either as frontline, they use the Pola BR, which is a combination of bendamustine and rituximab, and then
much easier to say as well.
Yes, and then as for relapse, they use the Pola R chip, and that's rituximab, cyclophosphamide, doxorubicin, and prednisolone or steroids. So they all combined. They all have different effects on helping make the chemotherapy more effective on treating the malignancy.
Thank you very much, Jenni. I'm going to hand back to Hilda. Thank you.
Thank you, Jenni. And with all these new treatments, is there still a role for transplant?
I believe there will always be a role for lymphoma patients with stem cell transplant. It's a great option for the complex genetic diseases, and it offers good consolidation for the patients to remain disease-free for a long period. And obviously with these high-intense chemotherapies, that patients lose a lot of their good cells in their body, and by having a stem cell transplant, it's a great opportunity to repopulate these cells and aid quicker recovery for patients.
Thanks very much, Jenni. I mean, just thinking about transplant, and all of the treatments and, first line, second line, if we're going to do a transplant or perform a transplant in some of these patients, I guess we need to be thinking about harvesting cells or collecting cells before we have delivered too much of the therapy that's then going to damage the stem cell reserve. When does that happen then, if you're not really thinking about a transplant, but you might want to keep it in reserve later on?
I guess that depends on the area that with the consultants, and it's all individualized for the patients. But I think the discussion would be with the patient very early on. I know in our centres that when patients go through these chemotherapies, it is always mentioned as a treatment option, and those options are always discussed with the patient quite early. And it depends on the level of treatment that the patient needs and at what level they are diagnosed with, really, to depend on what treatment starts when.
Thanks so much, Jenni. That's amazing. I'm going to bring Lorna in now, actually. Lorna, it's lovely to have you on the pod today. Can you tell us a bit about your role and the work that you do with the Lymphoma Coalition?
Of course, it's good to be here. Thanks for asking me. Lymphoma Coalition is a global network of patient organizations. We have 90 organizations in about 55 countries. So we have good global coverage and an understanding of those groups that are supporting patients worldwide in whatever capacity, as well, of course, as their caregivers. Those are always included in the programming offered. My role as CEO is more guidance and sustainability for the organization, making sure that we're well equipped to do the work we need to do. And the coalition as well does a lot of its own work in patient experience research. We're looking into what, so even though we ask questions about the disease and how patients feel through it, really we're trying to understand more the systems and the barriers and the extra supports that patients might need outside of what is generally provided in clinic.
Thanks, Lorna. I'm going to hand back to Hilda now.
Thanks, Lorna. And what do you see as the least exploited opportunity in lymphoma treatment today?
I've been thinking about this question since I actually saw it on the paper, and I was like, do I actually have a good answer? And I think really what we need to do more of is make sure we know which patient is going to respond to which therapy, because now we have more and more choices, and there are more coming. When we look in the research space in lymphomas, there's a lot more therapies in the pipeline. So if we're going to have all this choice, we need to focus some energy on making sure that we're giving these very expensive therapies to the right people, so that the patients themselves don't have to go through so many treatment options. They're getting the best choice for them, and that we're making the best use of the limited dollars everybody, or the limited money everybody has available in their own healthcare systems. I would like to see that kind of research happen. And then, we can figure out who should go to CAR T earlier, who should go to transplant, who would do better with a bispecific antibody, et cetera, et cetera.
Thank you, Lorna. We head back to Michelle.
Thanks very much, Lorna. And so you talk about all these expensive treatments and, being able to identify which patients are going to benefit from which treatments. And, I think would be amazing if we were there today, but unfortunately we're not. And there are often other barriers to patients being able to access treatment in Europe. And I guess I want to ask you what you think are the most common barriers to treatment access in Europe, and how organisations like the Lymphoma Coalition can help to overcome these.
Yeah, obviously one of the most common barriers is just plain and simply you can't get the therapy you need where you live. There's limitations. Not every center can offer CAR T. Not every center offers transplant. Some countries can't offer certain therapies, the newer therapies, because of the cost involved. And so, access is really the main challenge for most patients. When we look at how we can potentially change the system, patient organizations are asked to participate in something called health technology assessment in some countries, which is the process by which new therapies are actually approved for use in their country and added to the formulary so that patients can get them free of charge. But in other countries where there's no such vehicle, not everybody does this kind of work. We call it HTA for short, health technology assessment, in a way that invites patient groups to participate, but sometimes we force our way in. And as well, there's an initiative in Europe called UNETA, the European Network into Health Technology Assessment, where they're looking at perhaps if we can take some of those processes that are really quite involved and take a long period of time and combine them and make something that happens just Europe-wide that the individual countries can use. We are one of the small group of nonprofit organizations that is at that table, so helping shape that moving forward. We'll see how that goes. It's always tricky to get lots of people in lots of countries to agree on one process, so we'll see how practical that becomes once we get to an end result. I will say for patients as well, we know the number of barriers has increased in recent years. When we asked, we do a global patient survey every 2 years. In the 2022 survey, when we asked patients who faced a barrier to getting their treatment, 70% of patients said yes. In previous years, it's been more like 30%, 40% of patients. So this is a significant increase. And we know some of those issues were due to the pandemic, but not all of them. And we also know that there's been some changes in healthcare post-pandemic that are continuing to add barriers. We've had healthcare challenges, healthcare staffing challenges. We've, countries spent a lot of money on the COVID pandemic that of course was not in anybody's budget. And so, there's some cost restrictions happening, and never mind the individual issues that patients themselves are facing. So it's very important to really see how we can expedite and help patients get the treatment they need as quickly as possible.
Thank you, Lorna. I mean, I think that once we've got to that point where we understand how to overcome some of these barriers, then we'll be a lot further forward in delivering healthcare that comes with equality and accessibility. Hilda, next question.
Thanks, Lorna. What impact do advancement in treatments have on impacting the outcomes for as well children and adults?
I mean, the new treatments that have come in are making a difference. We now see patients staying alive who before, let's be honest, they would have died. Especially when we look at some of the large cell lymphomas, the aggressive subtypes, if patients were relapsing, it was very difficult to provide extra treatments for them that would get them into a remission. There have been changes. CAR-T has made a difference for a subset of those patients, there is no doubt. So we have patients that are going into remission. Some of them, unfortunately, will relapse later within a few years, but for a number, they're staying treatment-free for long periods of time. I know hematologists are hesitant to use the word cure, but they're having long-term remissions, and that's a good thing. And now we're seeing the bispecific antibodies come into the space, and the clinical trials that support those therapy approvals are good. Right? Again, we're seeing a response from some heavily pretreated patients, showing that there's some options now, again, for long-term, and there's more in the pipeline. So, really, we're lucky in lymphomas. I work with some other leaders of other cancer coalitions that are solid tumors, and there's not a lot happening in those areas, right? They haven't made advances in recent years, and they don't have a lot of good news for their patients. We have a lot of good news. And I think that's an important message to communicate to patients is even though, there's a large number of patients that respond to these initial therapies and do extraordinarily well, if this doesn't work for you, we do have a lot more options now that we can try to get you back to being healthy.
That's wonderful. Thank you, Lorna. And we head back to Michelle.
So my final question for you, Lorna, in this section is, what can we learn from the Lymphoma Coalition as EBMT nurses group and as nurses working across the globe, and the advocacy work that you do with patients that's so important?
Yeah, one of the key things I think is we see some issues across the board with healthcare professionals and patients in their communication. So if we can find ways to have better conversations with our patients, it is a two-way gap. All the fault is definitely not with the healthcare professionals. Patients limit what they tell you sometimes. So, it's an issue we're working with on both sides, trying to get patients to open up fully. And even if, they think that a side effect or an issue that they're facing isn't really important, they should be telling you anyways, because sometimes there's ways to help, or sometimes it is an indicator of something more important, and they really should have a further investigation. So that's one thing. I do, have a very simple thing that I think everyone should ask a patient, and it is, what's the one thing that's bothering you the most today? Don't worry about what you think I want to hear. Don't worry about whether you think it's related to your lymphoma or not. What's the one thing that's bothering you the most? Because it can be something very practical about their family situation, not knowing, though, that there might be other resources they can access locally that can help with them with some of those personal challenges that they're facing, as well as the medical ones. And just from lymphoma specifically, we do see from our patients through the Global Patient Survey, and this has been, the number one issue. And the whole time I've looked at the survey, we've been running surveys since 2008. I joined the coalition in 2017. So I have a good portion of data looking under my belt there. And fatigue is the number one issue affecting quality of life, short and long term, for patients. And so how we can help support them with their fatigue would actually make their quality of life better. And so I do think when we look at different ways to advocate, even not just within healthcare systems, but in influencing clinical trials and influence best care, fatigue is one topic that we talk about so that we can make sure patients have a really good quality of life.
Yeah, I think you make a very important point there, Lorna. Not all problems are medical and need a pill or a prescription to fix them. And I think listening to the things that patients say are important to them is a really good place for us to start. Thank you very much. we're going to move on now to our quickfire round. We're going to bring you both into the conversation for your concise, best answers to the questions that we have available for you. And Hilda, I'm going to bring you in to ask the first one.
Yeah, we will start with you, Jenni. And what is the greatest advance in lymphoma treatment and why?
So I believe CAR T therapy is a great answer for the one of the best treatments available. It's just such a new novel treatment that we've learned so much from in such a short space of time since it's become available, and it just offers the patients just that extra lifeline of treatment, that they perhaps wouldn't have been available before, and a lot of the outcomes, I'm sure, with the data that's coming out in the next few years from all these patients going through, will just show that it's just been great for them.
Thank you, Jenni. And for you, Lorna, your answer.
If we look at lymphoma history longer term, then I do want to mention rituximab was where we saw the biggest change in survival rates. And so don't forget the powerhouses in the back that have been there for a while. In recent, I agree, it's CAR T. We'll see what happens with the bispecs and the antibody drug conjugates, but they're too new in the market yet to see long term.
Thank you so much. Michelle, for you, the next question.
Thank you. So CAR T, auto, allo, why? Jenni.
Do you mean more like the options? I think having the options for all of them is important, because every patient and every disease is different, and I think those options should always stay available for the patients, and just to individualize the treatment really for each patient. Thanks,
Jenni. And yourself, Lorna?
Agree that we really need to personalize care and personalize it well. If a patient was asking me about these 3 therapies and the impact they're going to have on their quality of life, then definitely I would guide them or tell them that CAR T, you have fewer usually side effects that are going to impact your quality of life, and fewer long-term issues, which for a patient is vitally important.
Thanks very much. Hilda?
So next question, what piece of information you know now would you give your newly qualified self today? And now we start with you, Lorna.
It's all going to change next week. I think that is that recognizing that there is going to be a lot of change in the lymphoma space, and that's okay. It's good. And we're all learning together. So let's give each other a little bit of kindness when we go through this, and encouragement and realization that not everybody's going to have access to the same level of information. So let's coach each other and get us all up to our best selves.
Thanks a lot, Lorna. And Jenni?
Yeah, so I think, even just doing the talks over the last couple of weeks that I've done with EBMT, I've just learned so much, and I think it's important to keep the education going, and to just promote it and encourage other people to do things like this.
Thanks so much. The last question for you, Michelle.
Thank you, Hilda. So what statement of today about lymphoma will still be true in 10 years, Lorna?
I would like to see some of these treatments be curative. So I hope there's going to be some change. But I think the one statement is every patient is going to be emotionally affected by their diagnosis. It doesn't matter what the outcome is. And so let's remember the psychological and emotional support that they need, as well as the physical.
Thank you, Lorna. And over to you, Jenni.
Yeah, I would agree. I think although the treatments they're so great now, and there's so much options out there for the patient, we still need to remember that the patient's journey is getting longer, sometimes a bit more complicated. So we need to be there to ensure that the patients are at the center of it all.
Thank you very much. Thank you very much indeed. I think that brings us to the end of our questions, and What an amazing opportunity it has been to hear from both Lorna and Jenni this morning, and their views and experiences around lymphoma, and really touching on sort of the new treatments and the opportunities that are going to be available for patients going forward. Thank you so very much. Thank you, Hilda, for co-hosting this pod with me, and huge thanks, Jenni and Lorna, for joining us today on the pod.
Thank you.
Thanks.
It was great.
Thank you. Thank you.
Thank you, Jenni and Lorna. So we had a really great episode today with Lorna and Jenni today. They talked about their experiences with lymphoma treatments and all the new treatments, and especially they emphasized the personalized care we should give to all these patients. And we had a really good topic today. So I would like to thank the team for doing this podcast, and also my wonderful co-host, Michelle, and hope you have a wonderful day. Thank you for listening.
Thank you.